Hello everyone, my name is Johnathan Kennedy. I'm a third-year emergency medicine resident at Orlando Health, and today I'll be presenting our research entitled Comparison of Emergency Department Throughput with Standard In-Person Triage versus Virtual Telehealth Triage. As we well know, the ED can be a fast-paced and chaotic environment. When volume overwhelms capacity, patients inevitably experience increased wait times, and often subtle but sometimes significant delays in care, whether to initial evaluation and stabilization or to further treatment and interventions as an inpatient. And this is problematic for many reasons, and there's growing evidence that increased length of stay in the ED is associated with increased medical errors, increased costs, worse outcomes, and poor patient experience. In part, because of this, there's been an increasing emphasis by administrators and payers like CMS on ED throughput as a marker of quality of patient care. In efforts to maximize patient safety and quality of care, EDs are tasked with developing innovative plans to streamline patient flow through the ED. One potential tool in this endeavor is the use of telehealth and particularly virtual triage. This may show promise as a cost-effective and logistically feasible way for physicians or advanced practice providers to evaluate patients upon arrival and to determine the need for immediate in-person evaluation or diagnostic testing. This offers the potential for more accurate triage to the most appropriate level of care and to streamline the visit in its entirety by starting workup and treatment before a bed becomes available. One advantage of being remote is that one provider can cover multiple different facilities within a system or across a region. This especially holds value in our current pandemic environment with COVID-19 to protect our frontline staff by limiting exposure while conserving personal protective equipment. So with this in mind, the aim of this research study was to answer the question, does virtual triage using telehealth technology improve ED throughput? We conducted a cross-sectional study from January to October of 2019 at our Level 1 Trauma and Tertiary Referral Care Center, which sees over 100,000 patients a year. Data for the in-person triage group was collected from January 21st to March 21st, and data for the virtual triage group was collected from August 12th to October 10th. There was a 3-month run-in period for communication software testing and equipment training. Tablets with telehealth software were placed in each of our triage rooms. Providers were able to interact with each patient directly during the standard triage process in concert with the triage nurse. Providers were able to direct the physical exam and acquire more in-depth history to determine significant risk factors that would confer immediate management decisions, like the need for certain imaging or laboratory tests, or to change the triage level within the ED to our more acute area or to a lower acute fast-tracked area. Triage protocols were the same for both groups. Age, gender, triage level, disposition, and times were captured in an administrative database. Our primary endpoints were common measures of ED throughput. We recorded time from patient arrival to provider evaluation, time from provider to admission order, and total ED time in both admitted and discharged patients. This study analyzed a total of 35,690 ED visits. 18,120 were included in the standard triage group, and 17,570 were included in the virtual triage group. With respect to arrival to provider, there was a significant decrease in the time from arrival to provider with virtual triage at 27 minutes with a 95% confidence interval of 26 to 27 minutes versus standard triage at 30 minutes with a 95% confidence interval of 29 to 30 minutes with a p-value of less than 0.001. There was also a significant decrease in the time from provider evaluation to admission with virtual triage at 3 hours and 53 minutes versus standard triage at 4 hours and 9 minutes. And again, this was significantly different with a p-value of less than 0.001. In discharged patients, total ED time was almost identical at 3 hours and 38 minutes for both groups. In admitted patients, total ED time was not significantly different with 11 hours and 46 minutes for virtual and 11 hours and 44 minutes for standard triage groups. In conclusion, this data reveals that ED throughput times are either equivocal or slightly better with virtual versus standard triage. While the implementation of virtual triage significantly reduced arrival to provider and provider to admission times, total ED time was largely unchanged. One potential limitation of the study was the fact that data for virtual and standard triage groups were collected at 2 different time periods. Therefore, they may contain bias due to confounders related to the time of the year and other potential differences in ED resources and stressors at each respective time. However, this remains a growing area of interest, and future studies are needed to evaluate opportunities for provider evaluation and triage at other community hospitals within our system, the utility in leveraging freestanding ED providers for staffing, and directly evaluating both provider and patient satisfaction. Please post any questions to the comment section below, and thank you so much for listening.